and we have a fairly tight agenda. We've only got an hour. The emphasis of this meeting is really on the practical, on pragmatic solutions and innovations around inequality. So if we could stick to the time, we won't be having questions in between the items. So if you could keep questions right to the end of the meeting, and if time allows, we'll take questions. Also, if you want to put questions in the chat, they could perhaps be answered after the meeting. So without more delay, just to say we're absolutely delighted this morning to have Shahana Ramsden joining us. Shahana is Head of Workforce Transformation for the South East region, also co-chair of the South East COVID-19 BAME Disparity Advisory Panel. What would be great if we could just go around really quickly and briefly and introduce ourselves so Shahana knows who we all are. So I'll introduce myself first. I'm Anne Oates and I'm a Quality Improvement Lead working in Cardiovascular Network. So whoever...
Elaine's next on my list, so maybe if I just call people's names out.
Morning, Elaine Gold. I'm Quality Improvement Lead for Respiratory within the Cardiovascular Network.
And then Elizabeth. I think you might be on mute, Elizabeth.
There we are. You can hear me now. Hello, I'm Elizabeth. I'm lead for the NHS Diabetes Prevention Programme for Hampshire and Isle of Wight.
And then Yvette.
Hello, I'm Yvette Garden. I'm a Quality Improvement Support Manager for Maternity and Perinatal Mental Health.
And Fifi.
Hi, I'm Fifi Ma. I'm one of the Quality Improvement Manager and I'm mainly doing the informatics support here.
And Gail.
Yeah, morning. I'm Gail Thomas and I'm one of the Quality Improvement Leads and I'm currently supporting the Mental Health Support Teams programme across the South East.
And Hayley.
Hayley Wall, and I'm currently sort of split between a lot of areas at the minute. So HTV, the regional comms team, and supporting Anne Eden in the business office.
Communications guru. James.
Testing me today.
Hi, James Carter, work within mental health.
Yeah.
Jan Ratcliffe, I'm business manager / PA to Olivia for the clinical Hampshire Thames Valley Clinical Delivery Networks, and also partly redeployed to the mental health, learning disability and autism cell for the South East.
Jenny. You're on mute, Jenny.
Sorry, it's such a cliche these days, isn't it? It makes me laugh. Yeah, I'm Jenny Walsh and I am the clinical lead for perinatal mental health.
Okay.
Okay, Julia.
Morning, Julia Coles, Head of Clinical Programmes, joint with Debbie, cross-cutting themes, focusing on personalisation, prevention, dementia and end of life.
Liz.
Hi, I'm Liz Cullen, Head of Clinical Programme for Maternity and Perinatal Mental Health, working across the South East.
Neil.
So Neil Sands, Quality Improvement Lead for Diabetes, Hampshire Thames Valley.
Paul.
Hello, Paula Halloran. I'm a GP and I also lead from primary care, Hampshire Thames Valley Diabetes with cardiovascular medicine as well.
Thank you. Rachel.
Hi, I'm Rachel Chappell. I'm the Quality Improvement Manager leading on dementia across the South East.
Rebecca.
Hi, I'm Becky Furlong. I'm Senior Quality Improvement Manager for Children and Young People's Mental Health.
Sarah. Oh, sorry. Sarah.
Hi, I'm Quality Improvement Manager for perinatal and mental health and maternity, and I'm also working on homelessness during COVID.
Raj.
Morning, everybody. Raj Thacker, GP Plant Care Director at Bucks CCG, and similar to Paul, working across HTV with CVD and diabetes.
Thanks. And I'm Debbie Kennedy. You know me, Shahana, because we've spoken, so I won't introduce myself. Thank you. Are you okay to start your presentation?
Let's go. Brilliant.
Let's go.
Well, welcome everybody, and I'm going to be speaking about the Turning the Tide strategy, which focuses on addressing racial inequalities across our workforce and communities. I'm actually, my full-time job, I'm head of workforce transformation, but on a voluntary basis, I chair the Turning the Tide working group, which has, it's a new name, it's replaced the BAME Disparity Working Group. So, I don't know if you've read the Turning the Tide strategy, but when I first came across it and started working through the document, I actually felt quite emotional because it reminded me of how far we have come, but also how far we still have to go. Something you may not know about me is that I didn't actually want to become an equality and diversity lead. I started off from the age of 6, I wanted to be an English teacher, and I did achieve that. I became a teacher of English and French. But very soon after starting, I became concerned about the way our young students were being treated. I felt our BAME students were more likely to be stereotyped. I felt they were more likely to be reprimanded and less likely to be promoted to the top set. I remember thinking a few years into my teaching career that if this is how we're treating our young BAME students, what hope do we have for the future? So I actually left teaching and became retrained with the Commission for Racial Equality and began to represent discrimination cases, and then spent the rest of my 30-year career leading national and local equalities programmes. But back to the Turning the Tide strategy, we know that the risk of death for Bangladeshi communities is twice as high than for the white British communities. We also know, unfortunately, the risk of death for BAME communities overall is 10 to 50% higher than for non-BAME communities. So the data is very stark, and we know that there's this heightened interest in equalities. We've seen this increased desire to change. For example, in June this year, we saw people dismantling the statue of Edward Colston, who represented the inequalities and injustices of the slave trade. And this had a huge impact on our communities, who are giving us a very strong message that we need to dismantle the structural, institutional and interpersonal racism that people are experiencing. So I'm going to take you through these slides. I'm not going to go through them all, but they will be sent to you at the end of the session. And at the end, I do have 2 good practice examples, but I know that you also have examples, and I'd like to stay to listen to some of those. So I'll speak for about, hopefully no more than 7 minutes, and do feel free to cut me off if I get carried away. So you've seen the data, so we will skip that slide, and you will have a copy of the data. So the history of health and social inequalities is beautifully represented in the Turning the Tide strategy. It was in 1980 that the Black Report began to talk about those socio-economic inequalities that people experience. And the Macpherson Report had 70 recommendations for change to address institutional racism. And I won't go through the whole list, but you can see year after year, more reports have been written about what needs to change. But there's still more to do. So I'll take you to the next slide. So, next slide, please. The Turning the Tide strategy talks about a need to move from supplying support, advice and guidance towards working with our systems to ensure this growth of deep and meaningful consciousness about BAME health inequalities and employment inequality. So the question I ask is, what does that growth of deep and meaningful consciousness mean, and how do you achieve it? And the way it can be achieved is not through a linear strategy, not through we'll do this and this will happen, and then we'll do this and this will happen. This is complex change, and we're having to turn the tide on years and years of discrimination. But fortunately, good news is that the People Plan has equalities at its heart, and also when the Phase 3 letter was developed, it was very clear that equalities addressing the most deprived neighbourhoods and the support needed for BAME communities is core to delivery of the Phase 3 letter. Next slide, please. I've talked about Edward Colston and the historical inequalities that we want to dismantle, so I'll go to the next slide. And this is what we were talking about, the importance of addressing structural, institutional and interpersonal inequalities. So with structural inequalities, there's something about the socio-economic disadvantage that people experience in our societies, either because of where they live or because of the type of job roles they have, or because of the discrimination they experience. So that's the structure of society within which we live. Institutional is very much about thinking about the way we think, that unwitting prejudice and the stereotypical attitudes that affect the decisions we make as an organisation. And interpersonal is the challenges that people face on a day-to-day basis. And it's those micro stresses. And there is evidence, I don't know if you've seen the Professor David Williams, the Harvard University report, about the weathering effect of that day-to-day microaggression that people experience. So that's what our communities are experiencing on a day-to-day basis. Next slide, please. So what are we going to do about it? Well, we've come up with a plan which we're going to present to our senior leadership team in the region, and we're going to ask each system to develop their own Turning the Tide Transformation and Oversight Board. So this hasn't yet been agreed, but this is the proposal, which is we want them to really focus on embedding inequalities and addressing of that throughout the whole system. So each area will have their own Turning the Tide Transformation Board if this proposal is agreed. And that board will focus on what actually needs to happen to change the system. Now, a number of regions and a number of systems already have BAME groups or disparity groups, but our proposal is that these boards will be co-chaired with the BAME co-leader. There'll be 6 of them, so they'll be closer to the front line of delivery. There'll be a board assurance framework to measure their progress. So it won't just be about talk, it will be about action. To support that, in the next slide, we're going to develop a Race Equality Change Agents programme. So the Race Equality Change Agents programme is quite an exciting innovation. When I was head of diversity in NHS England and NHS Improvement, we had a programme called Diversity Innovators, and this was about staff who, sorry, my phone is ringing. This was to support staff who wanted to make a difference around equalities, but didn't necessarily have the expertise or experience to deliver on this agenda. And so ReCap what it will do, it will work with staff across different providers, whether it's health, social care, local government, private, independent sector. And they will donate, with the support of their line managers, a day a week or a day a fortnight to focus on a particular equalities issue. And in return, they will get intensive equality awareness training, and they'll understand how you manage change, and there'll be an engaging and enabling peer support community. So we're hoping that if we combine Race Equality Change Agents programme with the Turning the Tide board, we get that pincer movement with the whole system focusing on equalities, but the actual practical delivery that's required to make it happen. So next slide. And we in the Turning the Tide, we have 5 work streams, and you're welcome to join any of them. The population board and the population work stream is very active in creating a safe space where people can share good practice and learn about equality issues. They've organised several webinars to enable people to get together and share ideas. And then next slide. I know you've got a lot of good practice, but I've got 2 examples of good practice just to exemplify the sort of changes we want to see within the Turning the Tide strategy. Firstly, Surrey Heartlands have been completing community impact assessments. So they've developed a fantastic suite of intelligence products that explore how communities across Surrey have been affected by COVID-19 and what support they need. And hundreds of community members and people in frontline services were part of the community impact assessment. So they're interviewed, they had focus groups and they had surveys. And it's a really good example of how you work with the community directly to think about what needs to change, and you change with them in co-production rather than a top-down approach. Secondly, the workforce subgroup has developed a number of different programs. In OUH, they're working very closely on risk assessments to think about not just doing a risk assessment, but thinking about a more sophisticated response to risk assessment. So that if people are told they cannot work in a high risk area, that there's a stretch assignment or a redeployment opportunity, so they don't feel that this is going to limit their career. There's also a fantastic piece of work in Isle of Wight, where rather than looking at risk assessments alone, they're supporting the quality of the line manager conversation, and they're looking at risk assessment as part of a wider health and wellbeing check. So I'm sure you're going to come up with several examples, and I'd like to stick around for some of them. But that's an example of the sort of change we want to generate as a result of the Turning the Tide strategy. And that's it from me. Any questions, or can I pass back to Anne?
Thanks, Shahana. That was really, really helpful. Thank you. Are we going to move on from the slides, Hayley?
Yeah, I'm just switching between presentations.
Okay, so thank you for that. That was so helpful, and I know that questions can go up in the chat for later on. So if we can move on to our next presentation.
I'll just stick around for another 10-15 minutes if I can, and just listen in, and then if you don't mind, I will disappear after that for my next meeting.
Brilliant, thank you.
We'll send you the recording, Shahana, so you can dip into it when you like.
Thanks. Thank you.
And do you want I just go and start? Hi, I'm Fifi here. So there's just we're going through.
Fifi, your connection's a bit dodgy.
Can you hear me?
It's a bit crackly.
Crackly. What can I do? Should be working fine.
That's better.
Yeah, that's better.
That's better. Is this better? Can you hear me?
That's better, yeah.
Okay, or I'll use another one.
Thanks, Fifi.
Hi, can you hear now?
You might need to turn yourself up a bit.
Okay. So I'm going through only 3 slides here, and then to just give a little bit of idea or flavor about the Southeast region. So the first slide is an example. Also, most of them is linked by the Public Health England slides. And then the first one is about the GBD. The GBD, the full term is a global burden of disease, and then it's trying to measure all the hundreds of disease about their injury, risk factor, disease, and then to try to quantify the health loss. And then here you can see that there's a list about the 8 conditions, the top 8 conditions in the Southeast, as measured by the total disability adjusted life years. So, or we call it DALYS, so dailies. But dailies mainly is measured by 2 things. One is the years of the life loss and the illnesses lifted with the disability. So that system, they contributed by the top 8. So we can see the main one is like a lower back pain. The second one is ischemic heart disease, and then the third one maybe COPD. So this just give you just tiny, you understand your thing. So if you want to detail, because Public Health England do publish the pack for the STP as well as the local authority level, so you can the whole pack is about I can't remember, maybe over 50 pages, and then they can go into each of the topic, and then you will be able to look at the variation by ward. Can we go to the next one, please? Okay, thank you. Choose is the declaration. This is the latest data in the 2019. Has just published this year, and then the Public Health England also have a online dashboard. So if you want to know the link or detail, just email me. I can let you know where is it. And here the picture is the Southeast region, and then on the right hand corner, you can see the index is a 15.47 as a Southeast region. What does it mean? But there, and then you can see like the Southeast region is the least deprived region in the England, but the range, you can see the score within the area is between 0.54 and 77.90. And in the bottom, you can see that that's the most deprived area at the local lower super output authority level. So some area, and then you can see the picture of the map as well. You can see more darker color, that means they're more high deprived area. So some like in a Medway or in Hastings, Portsmouth thing. And then in the left side, I try to cut it down like to by the geographic area, the differences between the 2015 to the 2019, and then you can see the most deprived and least deprived, but you may need to match the color, but I can tell you now that like the dark blue one, the lowest, the most deprived areas in Southeast is like Portsmouth, and then Southampton. Let me see. Somewhere I wrote it down because the color is difficult to see. And then Medway in the green, and then the orange yellowish is like Kent, and then the not really bright red, but it looks like that is a Slough. So this is our most deprived area at the Southeast. Can we go to the next one, please? Yeah, so what does it mean for the declaration? So we can see in the slide, we're talking like the gap in the life expectancy by the declaration. So you can see that in the Southeast England, Southeast region, so the most deprived life expectancy in the male is 76.47, but the least deprived, the life expectancy at the male is 83.3. So the gap is like 6.7 years gap. And then like for the female, it's a 4.8 years differences. And also you can look between the differences between the male and female by the gender. Like even in the most deprived area, the male and the female, the gap is like 4.5 years. And then in the most least deprived is 2.8 differences as well. So that is a you can see the disadvantage in the most deprived area. Their life expectancy definitely is shorter, like the gap here. And then in below, you can see that the contribution by the disease. So the highest proportion in the male and female also like the circulatory. So for example, in the 25.9% of the male contribution to the gap, that means like 1.73 years the life year gap in here to the 6.7. As the female is the 26.2% contribution to the gap, which is 1.27 years gap. So this is only 3 slides I try to show you, give you an idea what is the available data set around our country provided by the Public Health England. Definitely we can do more in that to go by the level, by the area, because you will see different area, they will have a different variation of the gap of their declaration. So like in the right hand, their gap may be even higher than the Southeast, 6.7, but they may be 9 point something year gap, something like that. And then, so I just give you the phrase here, and I will stop here. Yeah, but feel free to contact me for any data or anything you want, a particular topic, or you want to get the slide from the Public Health England, please feel free to contact me as well. Yeah, I give it back to you, Annie.
Thanks, Fifi. That was really, really helpful, and thanks for all your work on that. I'm sure people will be in contact to follow up and get more information. So thank you. Right, I think we're moving on now to pre-diabetes. Elizabeth is on the call, I know, and the team have done a huge amount of work in the diabetes prevention programme, and we're so fortunate we've got a short film clip from Akib, who is the diabetes coordinator for Ingeus in Southampton. So this is a short film, it takes 8 minutes, and I thought it was excellent when I saw it the other day. So if you could let us see that film, Hayley, please.
Hi, my name is Akib Fudalahi, and I'm the diabetes health educator for the NHS Diabetes Prevention Programme, and I currently cover the Hampshire and Isle of Wight region. I'm very passionate about supporting patients to live a very healthy lifestyle who live with pre-diabetes, especially those who are from a BA-ME background. As you know, people from this ethnic minority background are more predisposed to type 2 diabetes and its complications. Before getting into this role, I did my master's degree in diabetes best practice from the University of Southampton. And in my master's program, I was able to do my own dissertation project tailored to South Asian people living with type 2 diabetes. In this project, the purpose of this was to understand the lived experience of South Asian people living with type 2 diabetes and understand their feelings and thoughts of the treatment regimen they're receiving, and also how they generally feel living with this long-term condition. So I was able to interview patients in the Southampton community, and what I found was, from my patients interviewing them, was that wasn't much culture in the healthcare services they received, not much understanding of the culture when it comes to prescribing medication, the treatment regimen, and really having that understanding of the culture, the background, and the religion side of things. And that's really helped me as a healthcare professional to use this information into my daily practice, where I can take it to the next level and add in more diversity to my clinical practice. So since joining my role as a diabetes health educator, I was able to add in more diversity to the current team. And since delivering sessions to my patients, there wasn't much diversity in the room. And I'm from Southampton, and Southampton have a large BA-ME community, and seeing not seeing much people from that ethnic minority backgrounds in the program was concerning. So part of my role, I had the privilege to work alongside with Southampton City CCG, alongside with my program manager and colleagues in the CCG team, and we both share the same aim to increase the uptake of BA-ME people in the NHS Diabetes Prevention Programme. And we were able to identify the BA-ME people living in the Southampton and Portsmouth communities, and also we were able to target GP practices that have large numbers of BA-ME patients. So again, I had the privilege to be the front face of the NHS Diabetes Prevention Programme, where I'll be attending lunchtime GP practice meetings, and I'm able to liaise with healthcare professionals on how to refer patients, what we offer in general, and how we can increase uptake of BAME people into the service. Also, I'll be attending target days events alongside with my program manager, where I'm able to hand in more resources, more leaflets, and basically having that interpersonal relationship with diverse healthcare professionals of how they can refer their patients into our program. Other than that, I've been doing a lot of community work in Southampton. So I'll be attending health events that's exclusive to BAME people. For example, I attended an event in Southampton exclusive to Black, African, Caribbean people in a local church. I'll be attending community events in Southampton, such as the Southampton Miller, that's exclusive to the BAME communities, and also I'll be attending the religious events in the local mosques and gurdwaras. We are able to do some short talks on explaining what is type 2 diabetes, why do the BAME people have such high risk factors of this long-term condition, and especially in the South Asian events where I was able to talk coming from the ethnic minority background, the risk factors can be quite high, and also people from the South Asian background can have insulin resistance at a very young age, which is again a very increasing concern. So that's really how people from the BAME background to open their eyes a bit more and understand the condition in a better context, where we are able to take action into coming into the NHS Diabetes Prevention Programme. So in a nutshell, we were able to, with the hard work we've been doing, with the CCG team, we have launched our own sessions exclusive to South Asian people, and that's delivered in a language in Urdu, Hindi and Punjabi, and that's delivered by myself. And again, I'm privileged to be the BAME lead educator for this project. And basically now I'm able to see more South Asian people in the service, where I'm able to speak in a language they understand. I'm able to tailor the healthy eating side of things, snacks, the drinks, and the general lifestyle and religion to the South Asian people, where they're able to tailor the lifestyle changes into what works for them, and that interpersonal relationship with all my South Asian patients, where they are able to open up more from the group, they're able to share the challenges, they're able to share what's working well for them. That's also good to see this in the service. Other than that, to showcase our success story, my patient Hardeep Sohal, who completed all 13 sessions of the program, she also reduced her blood sugar levels, and her HbA1c blood test has shown to be normal range. And we were able to put Hardeep Sohal into the case study, where it showcases to the South Asian community that you don't really need to sacrifice your diet, your lifestyle, and all it is about managing healthy eating, is about cutting down on portion sizes, it's about managing your mental health, it's about managing your weight, and that can really make a big difference in reducing the risk of type 2 diabetes. And so we need more awareness in the community, where we can have someone like Hardeep Sohal as like a role model or like a diabetes champion that can really relate to other people from a certain background, that if Hardeep Sohal can do it, you can do it. So since COVID-19, we know we are in the middle of a pandemic, and it's having an emotional toll on people around the world, especially from a BAME background, where they are twice as likely to die from the COVID-19. So again, this has become an increasing concern for the BAME people, because they are more likely to be affected by coronavirus than other population groups. And on top of that, the underlying conditions that they can be more predisposed to can add in more further challenges. So we're very fortunate enough to still continue the NHS Diabetes Prevention Programme online, where we are doing it through Zoom platform, and everyone can take advantage of the sessions online. To be eligible for this program, you will have to go to Diabetes UK and do a quick risk score assessment, and that if that comes up as high risk, then you are automatically can refer yourself to the program. All you need is an internet connection or a telephone. We can just dial in, and from there you can just take advantage of the sessions that help you reduce the risk of type 2 diabetes and other other conditions such as high blood pressure, high cholesterol, and it can also reduce the risk of cardiovascular conditions. So it's basically you get a full package of that, including managing mental health. So which is great to still continue the journey online. We can still, in the middle of a pandemic where people are more, worried, to go out, more worried about, being affected by COVID, especially those who are living with underlying conditions, and having the service online can really help them, manage their weight, stick to healthy eating, portion control, and also improve their mental health. Hi, my name is Aki Fudalahi, and I'm the diabetes.
Great, thanks. Yeah, shall I just say that was great. I think we better push on quick because we're
absolutely
overrunning a little bit. So this is another group that experiences health inequalities that are talked about as a multiply disadvantaged group. That's homeless people. And this is a very short clip, shorter than the last, from a presentation by a clinical psychologist who works with homeless people called Nick Maguire. And he talks about how you can overcome the barriers, and that's what we wanted to focus on today. So, Hayley, if you're ready to go.
How do we do it? So taking a transdiagnostic approach is the first way of thinking that we talk about, and looking for those functional relationships. So formulating rather than diagnosing. So formulating, well, why? What is it that's driving the use? What are the kind of internal and external triggers? What are the kind of classical conditioning processes? What is it that's going on for the person which makes drug and alcohol use and self-harm behaviours sensible at the time? What makes it a sensible thing within the person's perspective for them to do? Now, Jill Leng was really helpful. She gave us a load of advice, and there's a nice guideline. Now, it's around serious mental illness and particularly psychosis, but she reckons that some people have used this to good effect to cause people to take on people suffering drug and alcohol use, because this nice guideline basically says you don't exclude. You can't exclude people from mental health services on the basis of their drug and alcohol use. Now, we may need to gloss over that psychosis may be a small part, so paranoia is often a small part, but if you do want a psychiatric category, then personality disorder would tend to be the one that would be used, but we would sort of prefer to talk about complex trauma, which has sequelae which look like psychosis and look like things like emotion dysregulation and identity issues, which then might get diagnosed as personality disorder. So clarity about how the mental health and drug use are functionally linked. Now, this is something we've been trying to do in Portsmouth, and so to help our mental health colleagues to help the people that we want. And what we've needed to do is very much engage on an interpersonal level with the people. So go and sit in meetings and help the mental health services to understand those links, those functional links between the two, rather than just saying, well, it's a drug use and a mental health problem. And that then opens up a whole world of treatments, and particularly MDT treatments. We published a paper around engaging inclusion health populations a while ago, and MDTs are essential, and they are essential in the effectiveness, it seems, of people treating people with drug and alcohol use. And of course, you need to have pharmacotherapy available. You need to have the ongoing community support available and psychological support available. So MDTs are really, really important, and often they're difficult to arrange. We need the support to get over appointment systems, and so place and structure of the way in which the care is delivered tends to be to the convenience of the care system rather than the convenience of the people, and support services to work around the drug use. So scheduling according to patterns of use, withdrawal, etc. So we know that alcohol and different drugs have, rather than this blanket, well, they've got to use because it won't be effective, we need to think in a much more nuanced way. So around alcohol, what we used to do is schedule the appointments early. So there would be, after a can to stop the rattles, then we'd do a bit of work, probably only 30 to 40 minutes work, before they needed to go and continue to drink. But in that time, we get a bit of a window where some of the psychological work can be useful. we need to think very carefully about it. Psychological work that relies on memory or on highly structured days tend to be less effective, but then nevertheless there are really good basic CBT systems which and methods of treatment which can be incredibly useful, and they're very concrete, and we've found them to be useful with people drinking. If it's cannabis, yes, it's entirely untenable. I've tried to treat people who are still using a lot of cannabis, and it's they're cognitively seriously knocked off. So that's about scheduling our appointments around the use and before. And so maybe earlier when they haven't used so much, so they're not able to make use of the treatment that we're offering. Heroin's really interesting, of course. After the initial use and the gouging phase, people can be incredibly functional and be right on it. So that, well, you know, the treatment is ineffective, we can get over through just nuanced scheduling and nuance of the work, and thinking very carefully about the kind of work that can be done. So that we need to be thinking about the difference in the drug use, and of course they're not all the same, and of course drink is not the same kind of drug use, so we just need to be thinking carefully about the contingency around those. And of course in the long term what we need to be doing is enabling drug services to go to the people. But that's our long-term plan, and I know that some services are already doing this and they're getting some great results. In terms of the individual,
that's it, Hayley, thank you.
Okay, hold on just while I switch presentations.
You're doing very well. I couldn't do it.
Brilliantly.
Can I share my screen directly?
Oh, you can, go ahead.
Yes, all right.
Oh no, I think James was next. Was James next?
Yeah, James is next.
James, yeah, so hold on.
Hi everybody. I'll share it if you want.
It's all right.
Oh, hold on, I can't see now because I've. Oh, how do I? Oh, okay, yeah. So, hi everybody. Yeah, I'll try and be really quick. So, as per the COVID-19, we were very quick to recognise as Mental Health LDA Cell the importance and registering the importance of COVID-19 and impact on those with existing serious mental illness and their health. The inequality involved is exacerbated or further lengthened or further widened as a result of COVID-19. So we were fairly quick to create a webinar at the end of July where we asked a number of thought leaders to come together and also give us some of the examples from across the patch. Slough obviously is an area across the southeast with the highest incidence of potential inequalities. Therefore, it was helpful to have brought the Slough IAP service along to discuss that. So I'll just quickly touch on their involvement. So we had the Centre for Mental Health, we had Autistica, who are the charity supporting people with an autism diagnosis, adults and young people with an autism diagnosis, and then obviously had the Slough IAP service come to talk. Okay, thanks, Hayley. So you might just have to flick through. So key to this point really is from the COVID-19 perspective that individuals with with existing mental health problems will be experiencing more of a difficult time at this point, and obviously therefore we can then extrapolate that to more generally people with a mental illness. They often have a mortality gap between them and the general public of around 17 to 20 years difference. That is obviously related to physical health conditions, cardiovascular, and also issues with substances, smoking, etc. But then also people with specific characteristics or from certain communities will also have found their COVID-19 experience more challenging. I've put a couple at the top right there. People that people experiencing poverty or people with poor experiences of low income, and those experiencing poverty are far more likely to be impacted. Their mental health would be impacted. Those from an Afro-Caribbean community have much higher rates of PTSD and suicide risk, and they are also higher presenters in the acute settings as well within mental health. And women, especially those women that are potentially have either experienced or are at greater risk of staying at home, that potentially have physical or social abuse during their lives. I won't touch on the next two slides, but something in the bottom point there about the economic impact of inequalities, poverty, poorest neighbourhoods, poorest super output areas, that side of things will experience a lot more. Also precarious employment and potential job loss and so on. So thanks. Hayley. Thanks. Oh, go back. So then we asked our Slough service to go. We need to go back one. The Slough service basically came on board and described their specific access issues that they had. They were presenting with a much lower percentage of their general population were presenting to their IAP services. You'll see this is the fantastic piece of work that I really wanted to highlight, is that there is this thing set up called the IAPT BAME Server Uses Positive Practice Guide, which highlights a lot of evidence and also a lot of good practice that services could be brought in, services can bring in, to better impact their inequalities, both from an access perspective and also from their service user perspective. You'll see here that the evidence is really strong in IAPT. It's an extremely outcome-rich service, that people with from a BME background or community are less likely to use IAPT services, less likely to complete treatment. Their recovery and their improvements, reliable improvements, I should say, in their condition are a lot harder to track and also harder to recognise. So the Slough service did a number of quality improvement pieces of work. You'll see bottom right, as well as doing their baseline work. And then if you go to the next slide, you'll see there the increase went from around, I think, 42 to a much more, if you can see the blue arrows here, the blue bars, I should say, from 2012-13 to 2018-19, they became a lot more aligned to the prevalence rates, and that access rate has continued to improve. Finally, the point around this is that there's an awful lot of evidence base within mental health around inequalities. The BAME Positive Practice Guide sets out some of the core elements which are set out there to improve access, and arguably, as has already been discussed, certainly from our colleague down in Southampton, that all of these improvements can be made. And actually, it's not just in IAPT. It's just that IAPT has a very strong evidence base and a very outcome based focus, that actually all of these elements could be utilised within services to help improve inequalities and improve access rates, as well as better service user experience and recovery. That was it.
Thank you, James. That was a rattle through. You did say you'd rattle through it. Thanks. Sarah, are you going to put up your slides, or Hayley?
There you go. I hope you can see those. So we've been looking at health inequalities in maternity and in perinatal mental health, and we started off with a series of webinars at the beginning of COVID, and through that we've actually started looking at quite a number of inequalities that have become more evident as we've gone through. So we've looked at, we started with the Embrace report. So that came out fairly early on in COVID, which raised awareness of BAME issues. But we've also covered domestic abuse, gender inclusivity, the armed forces, where people feel very isolated, gypsies, Roma and traveller groups, and a project about reaching fathers who were being excluded from maternity services initially in COVID. So I thought we'd focus on two of those. We're going to focus on the traveller community and on gender inequality. So we had two really great presenters, and I've borrowed from their slides, and the full webinars are available on the website. So one of the things that was really stark to me when we were seeing the gender inequalities and the Gypsy Roman traveller particularly was just the difference in the lifestyle and the types of inequalities that they were facing. So she explained how the camps work and how the different housing works, and the importance of community leaders in actually accessing people and engaging communities. She talks about how the children feel discriminated against, and this was from a school survey where they asked children how they felt and how people felt they viewed them. And I think it just really brought home how it feels at the other end of being discriminated against and having difficulty accessing services. The other key thing that came across was digital poverty. So many people couldn't read and write, and so if they were given appointments or if they were given information leaflets or given a time, they couldn't tell the time. And so one of the key things she brought out was the importance of, if you give somebody a form to fill in, asking whether they'd like help with filling in the form, because that means you can help, and rather than them taking it away and then not being able to access it. And the other thing was about technology. You know, the campsite she was talking about, or the traveller site, had very poor access to Wi-Fi, and a lot of people don't have IT access. So although there's a lot of a move towards using IT, actually that can inadvertently disqualify people, so they can't access the care or the innovations that are being rolled out. So it's just being aware of that. It's not saying that they're not feasible to do, but it's making sure that there are alternatives. Gender inequality was another really interesting session, and this is one of the key slides from this, which talked about the different language used. So the difference between gender identity, so the person's internal identity of whether they're a man or a woman or something in between, how they express that, so how they explain what their gender identity is, orientation and attraction, so whether they're sexually attracted to one sex or the other or both. And then the sex, which is the label male, female or intersex given at birth. And so it was really, to me, it was really helpful just having that really clearly explained, and I think this diagram explains that nicely. And I think the key theme that came across to us from all these different presentations was that actually sometimes it's not that the people are hard to reach, but the services are hard to reach. And this is one of Jenny's images of a building on the top of a cliff, and it might feel like that to somebody who can't access it because they don't have the literacy or the ability, the language to access it, or it just doesn't fit their needs. As in Debbie's clip earlier, you know, if you've got a drug and alcohol problem and you can't get to an appointment on time, then it doesn't matter how good the service is if they can't get to it. So the really skilled communication was key to good care and a positive experience of care. and that it was important to think about the format of the information, to listen to individuals or their community leaders and engage with them. And then really the key thing about personalising care around individual needs and choices, rather than around how the service was able to work. And just remembering that often it's the services and not the women or people who are hard to reach. Thank you. It was a whistle-stop tour.
Thanks, Sarah. I think we'll go back to the agenda, shall we? So I don't know, Olivia said that she would be okay about emailing some bullet points for the Deputy Director's update because she has to leave at 11. Is that okay, Olivia?
Yes, that's fine. Is that the final point on the agenda? Is that me?
Yes. You're the final point on the agenda.
Yeah. Okay. So in the last minute, I guess the one thing I want to say is that was a fantastic session. So thank you very much for putting it together. And I know that you've done more, and there's probably a second part to it. The question I wanted to put to everybody is, we never managed to put together a summary of achievements for 2019-20 because we were going through change at the time, and then the pandemic started. So could this be our summary of achievements? Because I remember, Debbie, you saying that the reason why networks were initially created and then they were identified and they flexed over the years was because they were due to, or their main objective was to address the global burden of disease as Fifi described, and address areas where the greatest years of life were being lost. So having a session on inequalities seems to come back to the core of what the networks were created to do in terms of addressing really deep-rooted inequalities. So even if some of these examples are more over the last 6 months than the last 18 months, I think it would be good either to gather all the slides into a single PDF document, maybe with some front sheet in front of each one of them, describing each of the networks as they were, and use this as a summary of achievements. So that's the question I wanted to leave. I do have to go to another meeting, but if you have a few minutes and you want to discuss or put in the chat or have separate email discussions about it, I think having done all the work, it would be a shame not to share it. So
No,
I'll speak to you
great,
later.
Olivia. I can take that as an action.